Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Welcome to KIMEcast. Tony Mikla, Russ Dunning. So we had a great weekend this weekend. We were out. Now, not everyone considers a great weekend what we might consider a great weekend, but so this Saturday we had a great opportunity to work with one of our doctor partners, take us with one of our partners with Stryker, which is a manufacturer of orthopedic products that are used in surgery. They have a surgical lab, it's called a wet lab, which is a cadaver-based lab. So unbelievable thanks to the people that donate their body to science in this way so that it can be utilized for studying and for research and to betterment of healthcare for moving forward. We were fortunate in school to have 6 cadavers go through full cadaver dissection in PT school at UOP. I know that at Sac State you can speak to the situation.
We didn't have 6.
Yeah,
I think we had 2,
and they were dry, right?
They were dry.
Yeah. So I think it's some more than others. Schools are different, but almost all of us in the healthcare field at some point get into this space, and it's a very intimidating place to get started. But I can't tell you the impact it has as a visually on a healthcare provider, knowing the anatomy and able to see it live. So huge thanks to those that donate, or families that donate for this cause. But this was a tremendous opportunity. We went down there and we went through a couple examples of surgical strategies around the knee. We talked about the shoulder and then even into the elbow, which was really insightful. And I think what's really important for us is to go to this environment. And we spend about 4 hours there, and we take a deep dive. The surgeon takes us through what it would be like and exactly the operation he's doing on a live being in a normal OR day. And it's obviously a little bit less formal, so he's able to kind of talk through why he's doing what he's doing and the details and the approach that he's taking and the options he's considering as to I do it this way and do it that way. And for me, that's one of the most insightful pieces of this is not only get to see the anatomy and the joint again and refresh that, which I think is huge weight. You know, when you see it once when you're in school is great, but then everyone should want to go back to anatomy again. You know,
Yep.
5 years in, 10 years into practice, go back to anatomy again and see it in the light of like, now I've seen 1,000 patients and if I go back to the anatomy, is it what's in my head?
The learning there is different. When you come back to it, it's just different.
Yeah.
It has to happen. If you haven't done that, you need to. Whether you witness a surgery or come back to anatomy lab.
Yeah. And the perspective is different where you're, in an anatomy lab, you first go, you learn everything, right? You learn all the muscles, all the bones, all the joints. You said there's 800 muscles. I can't remember the number anymore. I think there's 256 bones, something like that. It's a lot.
A lot.
Yeah. And as you practice, you learn to maybe that some of those are much more important than others in your daily basis, right? In your daily treatment and your daily approach. So it's really cool to go back and look at those in great detail and start really looking at the details. I remember when we were working this weekend, he was pointing out just this one little tiny ridge on the bone, specifically on the ulna. So when he would go in and create the tunnel to create the UCL, he was looking for that ridge, and this wasn't even something we would have studied but during my anatomy because working on the UCL wasn't exactly the highest priority at the time. So super cool, super great opportunity. So the first one we did was going into the knee. And I just want to bring this up and speak to it here as a result of, I think that the technology improvements and the way that we can do things nowadays, we being the healthcare providers, but certainly the surgeons, what they can do with the technology improvements is just remarkable.
Yep.
It's truly incredible. So if you think about it, like 40 years ago, we were doing open incisions and docs would have to, make a large incision, open up tissue, and then, go dissect through that tissue to get to the joint and then actually start to work on it at that time. And I just want to point out that the kind of tools that they were using at that time had some obviously great benefits, but compared to what's available now, they have a tool like what you would think of as a screwdriver or like a drill that it comes at every angle. So there's a 0 degree one, there's a 5 degree one, a 10 degree one, a 15 degree one, up to like 90, right? So there's and it's one tray of like all of these drill heads. It's literally carpentry, right? But what's great about it and why it's so necessary is that everybody's anatomy is different. So you once again get to appreciate that. And then you get to see the way that it's approached is different. So that if someone has a certain angle that might be difficult with their anatomy, instead of trying to wedge in and create with this angle, create an angle with the tool. They just get one at a different angle, so they go right in there. And it's very easy. There's very little collateral damage. Mm-hmm. Mm-hmm. And I think that that's what we see in the rehabilitation world is the collateral damage post-operatively now is almost negligible.
Yeah, in a very appreciative way, I would say great orthopedics tend to be gearheads. They love their gear. They love their tools. And you can appreciate that. If you ever watch any one of them work, the best ones understand their tools to a phenomenal degree, and they're able to say, hey, this shape of knee, this type of ACL, this type of meniscus, I need this. You really appreciate its artistry with very refined tools. And their skill matters a ton.
Yeah. This lab that it's Pacific Medical is who hosts the lab, and they're a distributor of Stryker products. And this lab is designed as a training center. It's one of the top training centers in the world for surgeons to go to and actually practice using tools and instruments to be able to do some of these procedures. But the point of that is when we're seeing someone post-operatively, we talked a little about scar tissue in the past. We're seeing so much less scar tissue. And that's not just from arthroscopy, but it's from the rest of the tools that are so clean now to get in and get out without causing any kind of collateral damage. A lot of the tools they're using have significant amounts of built-in protection. It's pretty cool. Like say there was a bone spur and they want to take down a bone spur, and there's a shaver, and on the back side of the shaver, it's totally protected. So only a small aspect of the shaver is exposed. So when that thing's, spinning around inside your joint, it's not hitting other cartilage or other tissues. It's unbelievably specific. It's pretty sweet.
Yeah. What I definitely relearned, this is, I think, my third or fourth time going to the anatomy lab that we've done as a business, because I think we've done it almost every other year at KIME. So maybe it's the fifth time. But you just really appreciate the angles the doctor has to hit, particularly for the ACL, and oddly enough, the nuances of a meniscus issue. And the doctor this time went in incredible detail about, if the meniscus tear looks like this, then it'll hit this angle and do this, and it'll tack down to the capsule, or it'll kind of hit it with a different type of thread. And the nuances with these surgeries is quite complex. It's not just you might see in the script, ACL recon with a meniscus repair, but that doesn't really appreciate the whole story of the details of what happened.
Yeah, 100%. And that's a massive situation, especially on the meniscus. How was it done? Where was the tear at? What size was it? How many of the different anchors or sutures did they use? And what type? In some cases, they would suture the meniscus back to the wall, the capsular wall. In some cases, a suture to itself. In some cases, to be debrided out. So those are all things we've known about and done before. But to see the technologies improve to make these easier, to make it slicker, every year it gets better and better, where the room for error is decreased.
I think no matter what, even with these ninja-like tools and ninja-like skill from the orthopedist, you still appreciate that once you start doing difficult activity, it can be a bumpy road. And every time you come back to anatomy, come back to surgical technique, and spend time with the surgeon, you get to appreciate those bumps in the road rather than get freaked out. And I think the younger therapists or the more inexperienced therapists, they get one bump 8 weeks down the line and they kind of freak out, like, oh, I think it blew. And you kick back to the doctor. A doctor's like, no, not really. It's gonna be bumpy. I did this and this. It's gonna take another 4-6 months to normalize. And so I think being patient with people's development, I've gotten that just by watching the process, watching a surgery, checking on anatomy lab, reviewing the surgical technique. I've learned to be very patient with progress. I've learned to have people work hard, but be patient. And having that dichotomy during the journey, you really get when you appreciate the full story. You have to appreciate the nuance of the surgical technique and how that was all done. So, when you see an ACL, but maybe there was a bone contusion and a meniscus repair, and, that ACL was shredded and they had to do a lot of clean up the stump and reorganize, you appreciate all the complexity of it, which allows you to rehab at an appropriate rate of progress.
Yeah, absolutely. Yeah, it's really incredible on the meniscus, the different tools they have now to be able to get in there and basically suture this tissue together in a very minimally invasive way. It's incredibly impressive. And the conversation here for those that are interested is the meniscus tear. Although healing is not guaranteed, we're seeing actually increased rates of healing for a variety of things, probably due to some of the technology they're using now. They're able to get in there and suture stuff down they couldn't go as well before. and get better holds. So
Stimulate bone. They're sandwiching PRP. They're doing other things to really magnify healing.
Yeah, it's pretty impressive. On the ACL specifically, this is a big topic. As we look at, like, the ACL is always a great topic of discussion, and progressive surgery, there's a lot of them. So that it's always like trying to get better. I heard Dr. Dugas give a presentation probably about 12 years ago now. He's with the Andrews Institute out in Birmingham, and he was at a nationwide PT conference talking about the 5 reasons why an ACL would fail. Like, so if they did a ACL reconstruction, what's the likelihood that it fails again? And there were 5 major reasons that he went through. 4 of them were a direct result of the surgical technique. And then one of them had to do with clearing the athlete too early to return to sport. So what's great is in 12 years, we've seen all of those things change. One of them under our space on this is return to sport and how fast that goes as a physical therapist. And we've seen that, like, for a while, like in the early 2000s, it was like, let's see if we can get him back at 6 months. Let's see if we can push this, see what we can do. And we've learned that the data says that that's not your best option. Can people do it? Of course. Are there unicorns? I don't know. But in this case, there are. There's people that can do it in 4 to 6 months and do incredibly well. That does happen. We don't exactly know why. But we know that the data supports that it's much healthier if you move closer to 9 months to 12 months or even beyond. The further you go, the healthier your choice becomes. I think that data can get a little bit misconstrued. I think if you're gone for more than 12 months from a sport, I wonder how likely you are to come back to it at that competitive level you were at before. So nonetheless, does your ACL re-tear again? No. But are you doing soccer or basketball or whatever the sport is at the level you were before? Probably not.
Probably not.
Yeah. So that's the reason probably you didn't re-tear it. So anyways, we've seen that change. We've also seen tremendous change in surgical technique. So a big conversation around surgery is always like what graft you choose. But for the last 15 years, graft selection is not really the problem. Graft selection is pretty matched up. So no matter what graft you choose, the data at the end of the day comes back to be pretty much the same. So it's not about graft selection as much as about surgeon selection, because there's other choices the surgeon has to make. When they go in and they're applying their tunnels to put the graft through, this just changed tremendously. So what they call is a vertical ACL or a vertical tunnels. And this is a direct inclination of what the tools are able to do. So when they drill the tunnel holes for the ACL in surgery, they used to use one drill that would go from the bottom all the way through to the top. And that was just a linear tool.
Clean line.
So in order to do that, in order to get the holes in, that was the only way to do it. Because you couldn't put it in the bottom for the femur and then bend the knee and then drill the tibia because it didn't work.
They were tool limited.
Yeah, and you couldn't get the angle on the tibia to do it any other direction. So they kind of had to do this vertically and did the best they could. Well, that led to a pretty vertical ACL. And that is okay if you're doing like a Lockman's test and you're just having vertical translation or translation in the forward plane, like deceleration. But we know the ACL usually tears rotationally, and we know that rotational torque is usually what the ACL is designed to prevent. So anterior torque as well as rotational torque. So because of the technology now, there's actually a drill bit. We don't even have this in like carpentry at the moment that I know of. I'm not a carpenter, so I don't know. But this is pretty sweet. It's like the drill bit's like a snake. So it has it tilts. So it just kind of angles out in any way that you want it to. So it's kind of like flopsy. And they just kind of angle it back and then tilts, and then you can put it on a guide wire now. So they can go through the femur, tilt the thing, and then drill at a different angle.
Yeah.
This is really incredible.
Drilling tunnels with one tool with multiple angles based off of guide wires.
Yeah.
It's insane.
Yeah. And it's really cool because all the drill bits fit over like a guide wire. So it kind of use the wire as your guide, and the drill bit just follows the wire. So they can do it at these random angles. So what's really cool now is they're able to bring the tunnel placement on the femur down a little lower and put it in more of a rotational access point, which is great. So to get in a little more detail here on the ACL, it's a 2-bundled type ligament. It has a very large fan attachment, especially on the femoral side. And when you tear your ACL, there's no way in surgery for us to reproduce that attachment point.
Yeah, reproduce a 2-edged, looks like a Y.
Yeah.
A Y-type tissue.
Yeah, it's a fan-based tissue. So any type of graft you put in there is going to be a tubular structure. It's not going to be fanned. So you put in this tube in an effort to simulate as much of the fan as you can, but there's no way you can do it, right? So they do the best they can. This is why surgery is not 100%, right? But now that they've got it where they got the footprint of where that fan is better duplicated with this new tool, which has been, that's not totally new. It's been going on now for 5 years plus, but the expertise of it is getting better and better, and the use of it's better and better. And I think we're seeing a change in the outcomes as well.
Oh, I think the nuance here is, you look at the variance of the person. So, there's gender, sex variance. There's pelvic width to valgus Q angle position, and then where's their muscle and what type of activity they do. And all those activities might lend itself to what type of stress is their knee, their knee under, not my knee, not your knee, the patient's knee.
Right.
And then they got to pick an angle. They got to pick a sweet spot somewhere between the anterior to posterior position and complete rotary. Because they're not going to do it entirely rotary and completely neglect the deceleration part. So they kind of do like this tweener. And, you got to really just trust a great surgeon to pick that angle.
Yeah.
And maybe they have their favorite angles, or maybe it's based off of size.
Yeah, there's some feel. It's a bit of art. It's a bit of an art, and that comes up a lot. And whenever you're in surgery and you're talking to a doctor or the doctor's, in this case, doing a lab with us and teaching us things and showing us the choices he's making, I think it's really critical to understand that you might get a protocol where you think, oh, it's an ACL. Like, oh, it's the same. ACL, same. There's other questions to ask. And if you don't attend these educational things to understand what's going on in the most current developments of this surgery procedure, you may not understand how to rehab this in a proper way, or how you might be able to progress this a little bit faster, or how you need to be a little more protective of certain things, especially around the meniscus. It's really, really, really interesting. But something to take away if you're not a therapist would be this idea, this nuance of the art of surgery. Mm-hmm. There are absolute laws, absolute rules, absolute mathematics of exactly how to do certain things, but in the human body, it's not perfect. So there's room for some flex.
Now those imperfections, I think, with me, when I consider which surgeon did you go to, I read the op report, try and get a full picture of what type of person you are, athlete, sport, sex, and then I put the whole thing together. And then we kind of look at how tight is your knee coming out, how clean do you get terminal knee extension, do the hamstrings work, how smooth is those first 3 months. It gets really interesting after 3 months, because you really appreciate the variation. Do you need to spend a lot more time on rotational control? Neuromuscular, going from strength with rotation to neuromuscular control to speed activity. And that could be as nuanced as curtsy step-ups and curtsy lunges to lateral lunges, as well as doing the karaoke with a little bit of form running, or doing more pronounced turn and goes and working on how they rotate in and out of a cone setup where you work on lateral agility. Is that going to be their difficult path? Or they're weak as shit and they don't have enough muscle, and you're spending an abnormal amount of time just developing distal quad strength and distal hamstring strength on both sides, because maybe they got two flat tires, as one of our PTs would famously say.
For sure.
So you have to kind of really appreciate, where am I going to put a lot of my emphasis from month 3 to month 8? And sometimes it's rotational control. Sometimes it's a lot more posterior line. Sometimes it's a lot more anterior line. And when people say, oh, this is the protocol, fat chance I'm going to have what is my number one focus? Because you can't have multiple number ones. So what is the big focus? What is number 1, then 2, then 3? And hey, we might get all 3 if we have enough time.
Yeah.
But I think those are the nuances of where do you spend your energy as a clinician. And in my experience, the lateral and the rotational control, you really got to get focused on. And if you have enough strength, you can do it.
Yeah. I just wanted to add to that comment. I think that you're saying that from a fine-tuning standpoint because 80% of the foundation is, the same, right? So you build a strength base, right. You're building a range of motion base, you're building your normal progressions of agility, change of direction. That's all gold standard. And then it's a matter of where am I going to add the 20% of my real time?
Yeah, and the issues.
Yeah,
I think it's whatever the issues were in that first big phase. Well, it's going to show itself.
It will. Yep, I agree with that. I think it totally does. You really kind of see this was a little tough early on, and then now I see that it's a little tough for you, and we add some speed and some stuff. It's still there.
It's still there.
There's still pieces of that there.
Yeah, it's. I think you learn a lot around that week 6 to week 12. The difficulties there, well, just magnify those difficulties, and they'll be there, and you're going to have to really hone that in. I'm impressed every time, whether it's the hamstring. I mean, the list goes on. There's like kind of 10 things that are like, oh, you got one of those, is it inhibition in a certain area, or it's an intolerance with rotation. Some ACLs, they don't like being stretched with tibial rotation. It's painful. Sure. And they can't do it for a while. Well, guess what? You're really not going to like it when we start rotating.
Yeah. You know what it's going to be sensitive to. I think that's a great point. Is that we see that rotational sensitivity, impact sensitivity, maybe flexion or extension sensitivity. We see some variations there. So it's really cool. I think it's a great experience to kind of get to see it, and then of course get in there and really kind of dive deep and truly get your hands dirty, so to speak, but get to work with the docs at a very close level as to what they're doing, how they're doing it, and then considerations for us to make.
Yeah.
On the rotator cuff, we had a good dive into the rotator cuff as well, and I think this is super interesting. I think one of the most overseen things from patients and therapists, but even more so than the ACL, I think the variance in the rotator cuff is the highest. So this, and they said this, this is something the surgeon spoke about as well as the reps, is that like this by far is you need to have the most options ready. So when you go in there and open it and you look at the tissue, you might have 6 to 8 options to choose from. And every rotator cuff tear is different, truly every single one. And it could be a vertical tear, a horizontal tear. It could be fraying. It could be a hole. There's all kinds of different presentations. And those things are all approached differently surgically. And then I think we're going to see different speeds of return on rehabilitation as well. How well it healed based on how large the tear was, what the tissue quality was is a massive factor. We don't hear enough about that. But I'll tell you, any surgeon, if you're a smoker or if you have diabetes, they have strong concerns around tissue quality. And you wouldn't appreciate that until you went in and opened a body and actually touched their tissue in a live situation like a surgeon gets to. And they will tell you there is some massive differences in a smoker or in a diabetic in tissue quality and how that tissue responds to the work they usually do. Drilling holes in bone, suturing tendons, whatever it might be. I think that's always really, hopefully that's powerful for those that have those issues.
Yeah, I think that's exactly the story from a prehab standpoint. If people know that they are going in for rotator cuff surgery, having a tendon that's had some work, that's done something, that's expressed itself, that has some strength to it, is going to allow the doctor to kind of grab onto that tissue with some better integrity. If it's a tendon that hasn't done anything in 6 months, they're grabbing on tissue that's in a very weakened state.
Yes. Go in strong and come out better for sure.
Yeah.
They're all big fans of that in a huge way.
And you definitely appreciate that. Like, I think the quality of tissue, like phrase, really speaks itself with any kind of rotator cuff repair. It's a thin structure. It's on the whole anterior aspect and lateral aspect of the glenohumeral tissue of the glenohumeral joint. And yeah, I a surgeon like 20 years ago was telling a patient of mine, hey, it's kind of like jeans. And when the jeans rip, I got to put them together. So yeah, I got to have some good tissue to kind of thread that through and approximate them. I've been using the ripped jeans scenario ever since.
I really like the jeans ones. I use that with patients all the time. I think that's a great idea. And how the rotator cuff probably functions best is that if you have a pair of jeans. Now, this doesn't happen anymore, so I'm not so sure if people understand. But back in the day, you would buy jeans, and they would not have holes in them. Yeah. And then you'd wear them enough and actually do work, like real work, like on a ranch or something, for enough times that they actually would start to wear thin. And then when they would wear thin enough, they would start to rip. Yeah. And maybe get a small hole. And once you get a small hole, you can catch on anything and get a really big hole in a hurry. Yeah. So this is where this comes from. But if no
one works anymore.
Yeah, but if you don't work that hard in jeans anymore, then this will make no sense to you. But it's strongly encouraged. Strongly encouraged, and it really developed a lot of character. If you watch Yellowstone, you could really appreciate this.
But people also come out sometimes very stiff after the rotator cuff tear. And when I tell people, like, hey, when you rip the jeans, the doctor can't just put them together and throw some thread. He's got to overlap and find some health to it.
Yes.
So you're gonna come out tight. Yeah.
Yeah. And this is where, as a therapist, you really have to manage your protocol. Like it's definitely not all rotator cuff repairs are created equal. That's the take home message here. So if you see cuff repair and, you're thinking, okay, a few weeks in the sling and then I'm going to do this, that's all guidelines. Yeah. But as a therapist, this is where I really want us to like doctor it up a little bit and like be like, make a decision, like, and engage, like, look at the tissue, not that you can see it, but look at the person in front of you, look at their tissue, feel the motion, challenge it with some load, pay attention to what happens. Like, if they're not becoming more inflamed, if they're gaining range of motion, if you're moving in the right direction, the body will tell you you're doing the right things. Mm-hmm. You start doing the wrong stimulus, and you'll see it'll get inflamed. It'll be tough. You'll be restricted, mm-hmm. and that could be because of the repair. That could be because of the amount of the damage that was previously mm-hmm. done, or it could be due to your progression. Yep. So you really need to be strategic about this and pay attention, and not just be like, oh, it is what it is, but rather, in fact, you can actually you can create really specific change. But also,
going back, reading the op report, appreciating what the doctor did in there, so you get the nuance of it. Is there any arthritis that might kind of rear its ugly head because the doctor didn't do anything for that unless he cut bones off and replace the joint. Yeah. So, reading the nuance of the op report, I think, is absolutely critical. Understanding the surgery, absolutely critical. Because really, your judgment of whether or not 85% range of motion is actually fully successful, 100%, we did great, rather than this like, well, it's, you can't touch the back, the mid back yet, so you're not done with me. Some rotator cuff repairs will never be able to do that. Yeah, so you have to understand where, what progress looks like and what success looks like for that individual.
Yeah, I'll say this, like, I know that the op reports can vary heavily. So to Russ's point, I highly encourage that you read them at the very least, and then move to communicating with the doctor directly as a secondary level. But when you're looking at the op report, one of the easy things to look at on a rotator cuff report might be like number of anchors. Like if they use 2 anchors or use 3 or 4 anchors, that will usually give you an idea of how large the tear was. And if they're using more than 2 anchors, then it's a pretty large tear moving into the massive phase. So that's one indication to look for. You might also look at, they might indicate like the size of the tear as far as like millimeters. Say it was a 5 millimeter tear or 3 millimeter tear or whatever. So you want to get some perspective on like how large it was and what kind of impact you have. Because the larger the tear, obviously there's more tissue to close, to Russ's point. Got to suture it up, sew it down. When they're done with this thing, it looks kind of like a knotted mess. This doesn't really, the fibers aren't aligned, it's not this beautiful thing. So it's kind of knotted up, kind of messed up. In a live person, when they're doing this, they're trying to cause the tissue to bleed on purpose. So they'll go into the bone and they'll rough it up and then make the bone bleed. And then they place in the anchors, bring the rotator cuff to that bloody bone bed. So it creates a scar. So it creates a healing opportunity. You need to have blood to heal. That's why you need cuff surgery in the first place, is it doesn't heal itself because there's no blood supply. So they got to get blood to the area. So it creates this kind of knot, this almost like a bruise for sure. Mm-hmm. So you got all this tissue tied up. You got this blood going. It's going to kind of clot and firm up a bit. So this is why early intervention for me is really, really important. And not trying to gain all kinds of range of motion, but just get a little bit of passive range in there early on, so this thing doesn't just kind of like knot up and lock up on folks.
This is definitely one of the procedures that I use, and I'll say it to patients, I use the Goldilocks method. I don't want too fast, I don't want too slow. You want clean progress with passive motion, then active motion, and very slow strength build. I don't want you too fast, I don't want you too slow. Yeah, and if you are too fast, I'm putting the brakes on. And, if we're not progressing enough, then I start asking a lot more about lifestyle factors, sleep factors. Are you getting outside, going for walks, as well as doing your home program? So you got to get a feel of what people you need to speed up. And it's not usually speeding up doing the exercises. It's usually actually more about health. But the Goldilocks, genes and Goldilocks, those are my 2 thoughts for rotator cuff repairs.
Those are good. It's a good go-to here for sure. Yeah, I think it's a unique condition. It's one of the more unique conditions in the body that is a repairing of a muscle. We don't see a whole lot of like muscle sewing back to the tissue or to the bone. We get it in the Achilles, where you get some tendon being sewed back to the bone. You get it here in the rotator cuff. You might get a lateral epicondyle situation, but other than that, there's not a whole lot of these examples.
It's an energy capacitor. Yeah, it's designed to hold a stretch and recoil, transfer force. Yeah. Achilles, quad, bicep, rotator cuff. Those are the 4 that kind of come to mind on and they're, them. They're difficult. It's long to rebuild an energy capacitor.
It's a very slow process. Yeah. You got 3 to 4 months of just the healing phase, and then develop that thing to be strong, and then develop to be reactive, to your point, to actually do what a tendon does. You're asking for a lot. So it takes a minute. So it's definitely a long process. But that was super good to see some of the stuff there. Once again, the tools are continuing to be more and more incredible as far as being able to get the angles to do these different kinds of repairs is really, really impressive. On that note, we did talk about the labrum quite a bit. So around the shoulder, we've got a labrum. So we talked about dislocations, talked a little about managing the biceps. So talk about dislocation quickly first. The idea of dislocation. So if the shoulder dislocates, basically you're going to tear the labrum off. It's pretty much impossible to dislocate the shoulder and not tear the labrum. So as the shoulder comes off the socket, the labrum peels off, and you get this tear. And what's gotten better and better with the surgical technique is the collateral damage of the surgery now is so minimal on this that if you have one dislocation and you continue to play sports like football, especially wrestling, contact type sports, the odds you dislocate again are like well over 90%. If you don't play contact sports, it's still like 70 to 80%. So it's extremely high. If you're not going to play sports at all, then your level drops significantly. So I've dislocated my left shoulder probably the better part of 20 times. Mostly subluxed. I've always been able to reduce it myself, so it's not fully dislocated for that matter, I guess. I have no pain or no symptoms and no dysfunction on a regular basis, so that's fine for me. I haven't elected to have surgery on it. But if you're going to go back to play sports right away, and depending on your age and what you're trying to do, the indication is pretty much have surgery as soon as possible or whenever it meets the soonest goal. So we have football players and we have folks that are mid-season right now, have active dislocations, or they've dislocated, they've been reduced, they want to go back to play. And with a tremendous amount of work and rehab, that's an allowable option. They can make it worse, and they likely will make it somewhat worse. But the repair is tremendous where they can actually get back and do, after the surgery, the relocation rate's extremely low. So it's one of those things that's become almost an easy yes, where it's like, hey, shoulder dislocation, you have surgery, go ahead and get a Bankart repair, and the odds of you going back to sport and doing very well are extremely high. So it's pretty incredible.
And like you said though earlier, appreciating the individual. Is this person a little more hypermobile, and it's it kind of maybe it happened with ease. Whereas football, rugby, it was like I collided. It was forceful. Someone landed on the shoulder and popped it out.
Yeah, we spoke to that quite a bit as well, as this idea of if it's multidirectional instability, that's not a surgical situation whatsoever. So back in the day, they were doing like thermocapsular shifts, which was they'd heat the tendon or heat the capsule to get it to shrink down. That's no longer a thing. That they found out to be a negative impact. But that got to the point of doing it on many, many people, thousands of people. I rehabbed several of those back in the early 2000s. And then there was what's called a capsular shift, where they take the capsule, overlay it over itself, and then sew that together. That's very rarely done. The surgeon this weekend indicated that might be something to do in a multi-dislocation situation, just to grab a little bit of capsule and just tuck it slightly. But it's very, very, very mildly done, because so when you start messing with the tension of the shoulder, you take away its greatest asset, which is freedom of motion. So it becomes really tricky. Mm-hmm. But anyways, I thought that was it's great. It's cool to hear that, like, I mean, it's not great, but I guess it's good that like surgery is the preferred option in that situation, and it's a great option. You never want surgery to be your first option, but in that situation, like, it's a very, very good option. The outcome's very, very good. And I would say that I've seen that consistently throughout my career, that people who have that surgery do amazingly well. Amazingly well. And then the big talk, I think, is always around the biceps tendon. So nowadays you're seeing a big change in how this is managed once again, where rotator cuff repair, and there used to be like a slap lesion. So slaps were everything. Like when we first started, a slap was like the world, And a slap is a superior labrum, anterior, posterior tear. So it's a tear top of the labrum. It happens usually with somebody who's throwing or doing lifting overhead activity, but it's thought to happen over time. So it's very rarely a traumatic tear. It's usually a progressive type of damage.
An adaptive tear.
Yeah. Yeah. And that's actually a necessary tear. To Russ's point here is that there's a lot of thought that you can't throw a baseball without having a slap lesion. And then there's a balance of like, how much should you have? Is it a big one?
Yeah. Is it 135 degrees of layback? Or are you like, is it going all the way?
Is your labrum just like flopping around the joint? Or is it just kind of loose on one side? So there's debate there, of course. And we don't know the right answer necessarily. Again, it comes down to the person. How do you throw? What mechanics do you use? Your age, all kinds of variables. But the problem with the slap lesion is that the biceps tendon attaches to it. So when the biceps attaches to that, every time you throw a ball or specifically lift overhead, so like doing a curl doesn't really matter, but lifting overhead or doing like a preacher curl might be a factor. The biceps contracts and it pulls directly on the labrum. And so if the labrum is loose, now the bicep is pulling on a loose structure. It doesn't have anything to anchor itself to. And the bicep is heavily innervated, which means it has a lot of nerve supply. This can be quite painful. So it can develop quite a bit of inflammation and irritation. So the now gold standard, but 15 years ago was like first thought of, but now gold standard is to literally just cut off the biceps tendon.
For an athlete.
Yeah, for an athlete, for anybody. You come in, it's like, slap's a little bit loose and you got some anterior arm pain. Let's just cut your biceps off right now. So you don't have to worry about it, you know? Which is crazy. Like to create a tear to help people anatomically is very, very rare, once again, in the industry. And this is the only place, though, where a tendon attaches directly to cartilage in the body. So it serves a purpose, but that purpose is very rarely utilized. So it's a great idea that if you're going to get to the point of you're having shoulder surgery and you have some wear and tear on your biceps and there's some problems here, actually they go in and they remove it and they reattach it in a different place down onto the shoulder, in the front of the shoulder there. And that's for cosmetic purposes. You lose very little strength in your arm, like less than 20% of your bicep strength, so it's not a big factor. And we see athletes returning to sport. And you know, the gold standard here is John Elway tore his own biceps way back in the day playing for the Broncos and went on to win a Super Bowl with a torn biceps and didn't have it repaired at all. So proof in his throwing arm that you could throw and be effective and work overhead and be strong and play a contact sport and not have it matter. So
10 years ago, my entire caseload for shoulders, I was maybe at 80% rotator cuff repair, maybe 50% rotator cuff repair, and then 50% slap repair. Now I have like 80% bicep tenodesis, 20% rotator cuff repair. It's like it's like my main thing that I've treated post-operatively. And what's nice is like it's really easy to treat. It's about the easiest rehab ever.
Yeah, the surgeries are going to be great. You know, the surgeries it's a great surgery. It's turned into a great surgery. Now, when back 10 years ago, it was very, very painful. So I remember first seeing these and I was like, oh my God, this person's like excruciating pain. And the reason being is comes back to tendon fixation. So they thought that they needed this bigger screw and they put the tendon into the bone and then they would do an interference screw. And that interference screw would like wedge the tendon into the bone. And the healing process for that was just much more painful. And now they've learned that doesn't have to happen, that the tendon actually attaches back to the bone quite simply. So they kind of just flattened it down almost like a staple and just kind of flatten over the top, suture it down that way. And it does amazingly well, much less painful and much smaller screw into the ostium of the bone. So it does amazingly well. So it's really quite, that's just some of the amazing improvement where now someone can come out of shoulder surgery, almost be in a mild level of pain and get back to doing some things at a fairly rapid level with a procedure like tenodesis.
Yeah, so that definitely speaks to, you know, sometimes we're in this issue now knowing what you just said. Whenever you see an athlete, 18, 19, 20, 21, big diagnosed with SLAP, and then they're going to get a SLAP reconstruction or a repair. I'm treating one of those right now. It's very painful, very difficult to get full external rotation, full overhead movement. It's going to be a hard return back to sport given that SLAP. It's going to be difficult to say the least.
Yeah. I actually remember going to this lab 15 years ago and SLAP was the thing we did, the only thing we did. And we spent, hours doing SLAP repairs and the technique was amazing. Like, I mean, the guy doing it did a phenomenal job and the technique was incredible. And I remember rehabbing hundreds of those folks that did very well.
It was hard.
But it's hard. But
it's a long year.
Really delicate. Yeah, long year, really delicate, and made me great with the shoulder. I felt so comfortable after seeing it because I've seen so
you got to master the manuals, the PNF, all the different nuances of stretching. It's a lot of care to get them all the way back. I think that's the whole point. It's an incredible journey to fight your way back.
Yeah, and then whether or not you actually get, if you're throwing baseball, whether or not you actually throw 90 miles an hour again is a different story. Like you can do it, maybe not that fast, maybe not that consistently. So there was some trouble. So anyways, we've learned, and this is how it works. What's important for people to recognize is that it's a practice. Medicine's a practice and it's a growth, and this is how we get better at it. I mean, these people weren't terribly hurt. I'd say they all got better. The question is, did they get as good as they could? And that's what's led to some of the newer procedures is like, hey, we got good, but could we be better? And that's what's great about this process is that it's continued search of let's be better. and let's not modify the body and have surgery if we can avoid it. If there's a less painful surgery or an easier way to go, let's look at some ways to do that. So, one thing I will say that I think is always critical here, when you're working and you're looking at a surgery, or as a therapist, you get a chance to go observe surgery, is understanding like the collateral damage and what goes in to gaining either access to the surgery, like to develop for the surgeon to do the work. What do they have to move out of the way? We did not do this weekend, but I've done it before, where it's like the hip, for example. If we're working to do like an anterior labrum of the hip, to get through a couple inches of tissue, there's some decent long incisions. They have to reflect the joint capsule and then go in there and be able to then access the labrum and work in that area. So when they reflect that joint capsule, that has a very painful response, and it tends to stiffen up quite a bit afterwards. So it becomes a focal area of treatment where treating the collateral damage of just doing the surgery is something you don't know unless you've gone and seen one done.
Yep.
You know, and I think that's true. It's certainly in the hip labrum surgery is a really common one where you could take a look at that. Another example would be like, obviously on a total hip, like the reason why the total hip precautions on a posterior approach, which is, not as much practiced anymore, but if they still did a posterior approach, when they reflect these tendons or spray these tendons apart, that's what created all the precautions around total hips. Don't do external, don't do internal rotation, don't do adduction, don't do flexion, is because when they reflect that muscle back, you lose a lot of that stability. So I think those are things to be aware of. Those protocols exist based off of surgical strategies that are used. So as the surgical strategies change, you need to update your rehabilitation strategy and update your knowledge as to what's going on. And the only way to do that is working closely with your docs, working closely with your surgeons, and getting a chance to be with them so you learn and see these things.
Well, this is definitely where the learning is just nonstop. With every year, there's a little tweak, little nuance. I just learned about the peri acetabular, reconstructions that they're doing. This is brand new. I've never rehabbed one. And now we got, 2 elite athletes with those. And that's, where they literally just drill off the cartilage with a Dremel. And that means, by the way, you dislocate the hip going backwards. So it's an insanely gnarly technique, but I would have never known that until diving into the surgical technique, looking up YouTube videos, talking with the surgeons. And a lot of times these elite surgeons might also have people in their staff that might explain difficult surgeries. But this is the constant learning environment that we have to be in. And if you don't stay abreast of the new, then you won't be the best choice for people. That's really what it comes down to. Yeah, there's really some big subtleties. Now with are ACL, like doing the bear, where they're doing like ACL repairs, like to your experience. We discussed that quite a bit, and the details around that, like there's really the right choice of patient for that. It's not that it's a good procedure or a bad procedure. It's just, it's got to be the right procedure for the right patient. Was very, very important. We're seeing the internal brace idea around the ACL, kind of both ways again. Same thing, internal brace around the UCL, around the elbow is massive. They are having success with the UCL repairs as well as an internal brace. That is a return to sport much faster. We're seeing that in MLB and stuff. So we're seeing things evolve and seeing different things, and the rehab protocols are quite different for these strategies. So I can't emphasize enough that you get close to your people. If you're getting stuff, get close to your docs, get to know them, get in the ORs with them. You obviously stay abreast of the literature, but I think the literature is behind on this stuff. Honestly, I think it's we've had tremendous opportunities in partnering with Stryker and getting to know the Stryker reps. Specifically, Matt Upton's been great for us, and getting to know these Stryker reps and talking with them and having them teach us what are the techniques, what are the things coming down the pipeline. They want to. I think the thing here is orthopedists, the ones that we know, they love teaching. They love giving back in that way, but they also love educating the people that manage their patients. So, whether it is with the company that makes the tools like Stryker, or it's with the orthopedist, there's these opportunities to learn. Yeah. Well,
I hope this is informative for you guys and you're able to glean something from this and take it and run with it. So be happy to hear your comments. If you have anything to add to this, if you have any thoughts, have any questions, fire away in the comment section or go ahead and DM us, send us a message. We'd love to talk to you about it. All right, we'll see you guys on the next round.